So let's talk about vital signs. Your book gives four basic vital signs. It talks about just the four. That's pulse, respirations, blood pressure, and temperature. Those are the four basic vital signs that it gives. And we do a fairly good job of taking three of those. We don't do temperature maybe all that often or as much as we maybe should. The hospital is better about temperature. I think they record that on everybody, but we tend to only do it with patient relevance. We don't just necessarily take a temperature on everybody. Is there anybody that is taking a temperature on every patient? Are any of you guys doing that? Nah.
It'd be a lot easier if we had better thermometers.
It would be. So we we don't have good thermometers, and we're not taking a temperature on all of our patients. If they're if it's a hot or cold issue, we are. If we're suspecting fever, we probably are. But other than that, I would speculate that we're probably not. So, but the other three, we're doing a fairly good job of: pulse, respirations, blood pressure. We tend to get those on everybody. But let's talk about some other vital signs and things that we're measuring. Maybe not vital signs, but things that we're measuring in addition to those four. Can you guys give some examples of things that we're getting measurements of besides those four?
Blood glucose.
Okay. We're doing the finger sticks. What was that?
Capno.
Capnography?
Capno.
Yep. Get a finger stick blood sugar. That's giving us a reading. Capnography is giving us a CO2 reading, possibly a waveform if you've got it hooked up. What else?
O2 saturation is pretty standard with the pulse ox.
Yeah, O2 saturation. Any others? Last night when we had this discussion, somebody mentioned GCS. Which I thought was pretty interesting because it is giving you a concrete number. It's your interpretation of how they're falling into those three categories, but it does give you a concrete number. And GCS does have some importance because it should be playing a deciding part in how you're making transport decisions for your patients. So I thought that was an interesting one that somebody mentioned. So GCS, keep that in mind. You do have to come up with that number on every patient, whether you're doing it after the fact because you have to put it in your patient care report, or if it's playing any subconscious role while you're treating your patient. Let's hope that it is, because it certainly should be playing a role in your transport decisions at the very least. So keep that in mind as well. Pulse is the first one we're going to talk about, the first vital sign. So with pulse, hopefully you guys are actually palpating pulses and not just trusting that your pulse ox is going to give you a number. And I feel, sometimes we just kind of fall into that where people just stick the pulse ox on the finger, and when the numbers pop up, that's it. But I would encourage you to physically palpate the pulse, because there's some things that we want to verify and check. So number one is, let's try to verify that the number that we're seeing on our pulse ox is the actual number that we're palpating. So you can verify that your machine is working correctly, because machines do fail. So check those things with that. Also with the pulse, we expect to see a steady, constant interval pulse. We want it beating regularly, so we want it beating at a constant pace. And if you palpate the pulse, you will feel if there's any changes in there, if it's speeding up or slowing down. If you do it for a length of time, if there's any irregularities in there, you could feel those, and that should steer you to do some other things for your patient, and to check some other things. So if you're just hooking them up to a pulse ox, you may not necessarily get that that information that you would if you were actually feeling for the pulses. So how many of you guys are actually manually palpating pulses? Don't just say when they're unconscious, right?
To be honest, the only time I do it really is when the pulse ox is not giving me a great reading.
So as long as the pulse ox gives you a number you feel comfortable with, you go with it. If it throws you an oddball number that's kind of out of the norm, then you check and verify if the machine is right or not.
Yeah,
That's about right.
Okay. So you guys are putting a lot of trust and faith in those machines.
a little bit too much, probably.
Probably a little bit too much. So this is what I'll tell you.
Well, when I take a manual blood pressure, I can hear the pulse.
Yeah.
So,
yeah.
Yeah,
like,
that's a good.
I
That's a
always
good
try
point.
to make it to take a manual blood pressure before I even hook them to a machine.
Okay, we're going to talk about that too coming up here in just a minute. But with the pulses, I will encourage you guys to check pulses manually. And you say you're already doing that with your blood pressures, so it's not way out of the way to do a manual palpation of pulses. And we can you can see a chart in your book. If you're on page 451 in your book, there is a chart that gives you all of the pulses through the body where you can check them. And so if you're not sure where they all are, that'll help you be able to locate them. With pulse rates, there's another chart, if you flip over to 452, that gives you some normals. We're pretty good with the adult normals. We may not be as good with some other groups of people. So with the younger crowd, newborns, infants, toddlers, those types of people, we may not be as good with their normals. So there's a nice little chart that'll help you kind of refresh or get some numbers in your head about what normals are for those folks. Your book in this chapter is going to use a lot of those good 50-cent words for some things that are going on. So medical terminology is a big deal here. If we're dealing with our average adult, what is our normal pulse range that we're looking for?
60 to 100.
Okay, so we're looking for 60 to 100. If they are outside of that window, that 60 to 100 window, if their pulse is less than 60, how do we describe that? What's the 50-cent word?
Bradycardic.
Bradycardia.
Mm-hmm. And if they're over 100, they fall into
Tachycardia.
tachycardia. Okay, cool. Now, is it possible that somebody has a heart rate that's less than 60, which puts them in the bradycardia category, but is it possible for that to be okay?
Possibly what?
Is that okay for them?
It depends on the person, but I would say so.
Okay. So here's the thing that you need to get in the habit of with this.
Because if they're on like beta 2 blockers, that's going to limit their heart rate anyhow.
Okay. That's true. Beta blockers are going to keep the heart rate down. But it shouldn't keep it down that much though. But when you're doing your history taken and your assessment, let's get in the habit of, if you're not already in this habit, let's get in the habit of trying to figure out what each patient's normal is, because everybody's normal is different. So if you're dealing with a patient that's fairly athletic, does a lot of exercising, maybe does a lot of running or long distance running, the chances are that those folks are going to have a resting heart rate that's going to be fairly low. If they do a lot of running and working out type of stuff, they may have a resting heart rate that's normally in the 50s or maybe even in the high 40s, and that's perfectly fine for them. So if you see that, you're going to put your machine, Mark's going to hook his pulse ox up and he's going to see like 48 as a pulse, and he's going to have a little bit of cause for concern, I hope. So at that point, he'll hopefully take a manual pulse check, but he'll confirm that it is actually like 48. So what that should trigger, hopefully in you guys, is that should trigger you to ask some questions to the patients and figure out, is this their normal? And a lot of people do know their normal vital signs. They'll know what their pulse and blood pressure and stuff usually are. A lot of people, if they're diabetic, they know where their sugar numbers usually range. So you can ask them, do they know where this normally falls? And they'll say yes. So, and they'll tell you that, yeah, that's about right. So then that kind of takes the concern away from us, because seeing a heart rate of like 48 is a little bit concerning for us. But as long as the patient is awake and alert and doing fine and not complaining of anything, then that's great. So we shouldn't be too concerned. And if they tell us that, they run marathons all the time, then that should, confirm to you that it probably makes sense that their heart rate's that low right now. Does that make sense to you guys?
Yep.
Yeah.
Okay. So checking those things, looking at these numbers, looking at trends of these numbers, that's the kind of stuff that we want you to start focusing on. Not simply just slapping a blood pressure cuff on and writing a number down and putting it in your report, but we want to see how these numbers are affecting the patient, where these trends are taking us, and we want to investigate some of these things with a bunch of follow-up questions. All right. When we talk about blood pressure, I know Brian said he likes to do a manual blood pressure before he hooks them up to the machine. That's always good, because we get a good reference point so that when we hook them to the machine, we can see what the machine is saying versus what we just heard, and verify that the machine is good, or that we know how to take a blood pressure. So a good habit, if you're doing these, is manual vital signs before you put them on machines. I don't know that we're in that mode because we've kind of gotten spoiled and lazy, and everybody's using the machines a lot, right? So what are we looking at when we take a blood pressure? What's some bits of information that should trigger in our head? Nothing triggers in your head when you take a blood pressure?
Whether it's high or whether it's low.
Okay. What's high and low blood pressure called? What are those big words?
Hyper and hypotension.
Okay. So we got hyper being high,
And hypo
being low blood pressures. How do we define those? What's our parameters for hyper and hypotension?
(120/80) is normal.
Okay, so what's hypertension?
anything over 120-ish. In all honesty, I would say anything really over 130, 135, depending on their body size.
Yeah. It's actually a little higher than that. It's more like 140. 140 to 150 gets you into the category of hypertension. The American Physicians Association, or whatever that group of doctors is nationally, they're trying to raise that 120/80 standard that we've heard for the last 50 years. They're trying to raise that to 130/80 something, because the American population as a whole, it has a higher blood pressure now than they used to.
I hardly ever see anyone with a systolic that's like 120.
Yeah, unless they're on medication.
Porcupine.
They either have to be real healthy or on medication. So, but
be eating whatever they got that fucking fur from.
As a whole, we are eating a lot more fast food, eating a lot more salt, and people's blood pressures are higher than they used to be. So the norm blood pressure they're actually trying to raise. So if you keep up with that stuff and you're tracking it in medical journals or whatever, you may see some numbers that increase like up over in the 130 range, or maybe even a little more. So hypertension, probably looking at a systolic over 140. What about treatable hypertension in our protocols? Anybody have any idea what number we're looking at?
I want to say 160 for some reason.
Well, that's way low.
Yeah, that was a total guess.
Yeah, it's actually well over 200.
Oh wow.
For a systolic. Before our protocols before they allow us to treat it just as a hypertension problem. So it's
like 210.
It's like 220 or 220, I think, is, for whatever reason, is the magic number. It's up there. So, and I think I think that's a little too high, because I put that into, you're getting dangerously close to like stroke conditions. So, but that's what the protocols say for a lot of our agencies in this area. So blood pressures, that's the high end. What about the low end? What's a hypotension pressure?
Anything under 90?
Anything under 90, he says. What's important to us about blood pressure? What numbers and what things are we looking at? What do we need to see?
Needed to see a distinct difference between systolic and diastolic.
Okay, so we want to have a difference in those range. We don't want those numbers all that close together, right?
Exactly.
What else? What else are we looking for? We've talked about this a bunch already, especially with our shock type of patients. What's that 3-letter word we're looking for that deals with blood pressure?
The map.
There you go. We want to know what the map is. So if you're machine dependent on all your vital signs, you're in good shape with MAP because the monitors will calculate this for you and give it to you. Hopefully you remember the formula so you can kind of run these numbers through your head and figure it out. But what MAP are we looking for? What's the
Greater than 65, right?
Right. We're looking for at least 65. That's the magic MAP number. And what does that mean for us? If we have that number, what does that mean?
The patients are most
It means
likely
you have
adequately perfusing.
Yes. That means that the patients are perfusing. So we can kind of bank on if we can get a blood pressure, it gives us a MAP of 65 or higher, that our patients are adequately perfusing, which means that they are getting the oxygen in, that they are getting it circulating through the body, through the cells, and that the cells are able to use it and get their waste products out. So hopefully that's the case, but that's what we should be focusing on. So don't get stuck on a systolic of at least 90, although in most cases a systolic of 90 will give you a decent enough blood pressure that you can have a MAP of 65, but not in all cases. To play with numbers, and you can see how a 90 systolic with a very low diastolic won't give you a 65 MAP. So make sure that you're calculating that, or your machine is, or you are, to make sure that your patient is at a high enough blood pressure to perfuse. Okay, so that's some things to think about, some more in-depth stuff that we maybe don't always focus on. Your book also talks about an orthostatic blood pressure. Are you guys familiar with that?
Yeah, that's the blood pressure when you go from sitting to standing, right?
Well, it used to be a 3-step process. You took 3 blood pressures, one while the patient's laying down, then one with the patient sitting up, and then one with the patient standing up. But this current edition textbook only has 2 pressures, and that's when they're laying down and then standing up. So it gives you the process of how to do it. It says they need to lay down for 3 minutes, and then you take the blood pressure, and then they need to stand up for 3 minutes and then take the blood pressure. So what does that do? Are you guys familiar enough with this? What does it do, and what are we looking for?
I would guess that it puts a load on your cardiac output.
Okay. So what are we looking for? What are we expecting to see?
It stay within a certain range.
Yeah, and so we're doing this to see if the blood pressure drops. If they go from a laying position to a standing position, it's a little bit of a workload for them, but we're looking to see if there is a drop in blood pressure and or a drop in pulse, and that's going to give us a clue for a couple of things. Any ideas what we're checking for here?
Like fluid loss?
Okay, fluid loss. And that this usually is in two forms. So number one, first let's establish the parameters for this. So if we are doing this according to this textbook, the process would be have your patient lay down supine for 3 minutes and then take their blood pressure, and then have them stand up for 3 minutes and take their blood pressure. If there is a 20 millimeter drop in blood pressure, or if there is a 20 beat per minute drop in pulse rate, then, increase, if there's a 20 beat per minute increase in pulse rate, that would indicate a positive orthostatic. So when it's a positive orthostatic, it indicates two things for us. One is the patient is dehydrated, and the other is the patient may have internal bleeding. So what you would see there is a drop in blood pressure and an increase in heart rate, because that is the compensation mechanism. So if you get that, then they're positive with the orthostatic, and you can treat them for one or the other or both. It's actually the same treatment for us at that point. What's the treatment going to be? Fluids. That's right. Because if they're dehydrated or they have internal bleeding, what's the problem?
They're losing fluid.
Right. So how do we describe that problem? What is our big medical terminology for that problem?
Shock.
What kind?
Compensated.
Hypovolemic.
Hypovolemic. Yep, that's it. So we're dealing with a hypovolemia problem. They could potentially be showing signs of that type of shock, and our treatment for that is going to be IV fluids mainly. And if they have the other shock signs, then we'll do the other shock stuff. So oxygen, keep them warm, all that good stuff. But mainly and most importantly, fluids would be appropriate here. So these vital signs could trend you into certain directions, and should be sparking some things with you. So think about that as you're treating these patients. If you suspect that the person has dehydration, or you suspect there could be some internal bleeding, you can try this orthostatic blood pressure thing just to see if you get some pretty marked changes in the blood pressures, rather than just having them sit down or sit on the stretcher or lay on the stretcher. Try those different positions and take blood pressures and see if things change. And that'll help you when you're relaying this information to the hospital and justifying the things that you're doing for the patient. What about respirations? All patients are either 18 or 20, is that right?
No, maybe 16 sometimes.
Sometimes 16, just to mix it up. All right. So what are we checking for? Respirations are a lot. There's a lot of subjectiveness to respirations. Number one is we want a rate. So that's the concrete number. How many times per minute are they breathing? We get that rate. What else are we looking for?
Are they breathing adequately?
And what does that mean?
Struggling to breathe? Are they using compensatory compensatory muscles. I don't even think that's a damn word.
I don't think you said it right. So we have to qualify some things here. Number one, the rate, that's a concrete number. Everything after the rate is probably going to be fairly subjective. So Brian's referring to some quality. Are they breathing adequately? Are they working to breathe? You can look at people and see if they're putting any effort into it, if they're having to work, if they're having a struggle, as opposed to somebody who's just breathing normally and not really putting a lot of effort into it. So that's some things to think about. If you're in your book and you're over on page 460, there's a nice picture, and it points you to a lot of things that you can look at and check. A lot of some of the accessory muscles. You can see if they're using abdominal muscles, if they're using shoulders, chest, their position, nasal flaring, all of these things. You can look at the extremities to see how that stuff is going, sensation, edema. All of these things are going to play key into checking respiratory function. But what else are we looking or listening for?
You can look for a tracheal deviation.
Tracheal deviation. Okay. What's that?
The trachea will pull to one side if one side of your lungs is deflated.
Okay. All right. So usually that'll be that's usually an indication with like tension, pneumothorax type issues, and typically a pretty late sign. So they would be in decently bad shape by then. What else was respiratory assessment? What do we want to listen for?
Stridor, wheezing, wet sounds, no sound, whistling, anything, everything.
Okay, so we do need to listen to their lungs. We need to have them breathe in and out. We do need to take the stethoscope in most cases, and we need to physically put it on them and listen so that we can hear what's going on inside. You know, I mean, sometimes they're bad enough you can hear it without the stethoscope, but in a lot of cases we need to do that and listen. I think you know, we may be missing the boat on that a little bit. People may be getting a little bit lazy with lung sound listening, and it's pretty. Again, this is going to be somewhat subjective about what you're hearing, but it's going to steer treatments because, you know, different sounds mean different things, which means different treatments. So we need to have take a listen. We need to have a sound that goes with if we're doing a treatment, that sound needs to correlate appropriately to the treatment. So what I like to do is I basically have 3 categories that I use. So there's a normal sound. So as long as it's the normal quiet movement of air in and out, then we're good. And if they're not having any trouble breathing or complaining about anything, then I just say that's normal. Outside of normal, I use 2 categories because that steers the treatments. And the 2 categories I put them in is I either have a constricted sound, which is that's your dry whistles, wheezing, stridor, those types of things. You'll hear those high-pitched noises and it's all dry. Or I have a wet sound, which is going to be the fluid. So the rails and that sort of stuff that you'll be hearing from the fluid sounds, because those are probably the two main treatment directions that we're going to go in. So if I hear stuff that sounds like fluid, it sounds like there's junk in there, then I'm going to put them in that wet category, and that's going to steer us in one direction. And if I hear stuff that's that high-pitched whistle noise, it sounds dry, it sounds tight, it sounds constricted, then that's going to steer us the other way in treatments. Do you guys have anything that you're doing that's different from that, or how are you guys categorizing those types of things? No? All right. So think about that then. If you don't have your own system, take that into consideration. So we talked about temperature early in this, so let's get back to temperature. Mark said we don't have good thermometers. Typically, we have the red or blue thermometers. Is anybody carrying like the tympanic or temporal thermometers?
No.
No.
Perquimans might have them phased in or phased out. There's some trucks will have it, some trucks won't, and then the next thing you know, that we won't have them at all.
Right. And so, typically there's you always see the oral thermometer that's you have the red and the blue, right? And the reason that they have the two different colors is because one is oral and one is rectal. And I tell you, there's some doctors out there that you'll come across that they won't accept any temperature except a core temperature. So if you give them any temperature other than a rectal, they won't even consider it or give it any thought. So that's the only thing that they want. We generally take temperatures either orally. You can take them orally, axillary, or rectally. And now they've come out with the new technology. We were using the ear, getting a tympanic temperature, and now they've got these forehead scanning things. So they've changed a lot over the years. The technology's changed, the temperature taking has changed. But if you've been around the hospitals much, you may have run across a doctor that won't accept anything except the core temperature. So in those cases, it's going to be rectal only that they're going to pay attention to. So keep that in mind. And again, I think, we're probably not taking all that many temperatures, and only specifically if it's related to the condition or the emergency. If we're dealing with a temperature related thing, we're probably taking it, but other than that, we're probably not. So what I do want to tie to the temperature though is skin assessment, because the skin assessment is going to be indicative of temperature, and then it'll be different based on the temperature, right? So with temperatures, we have a low temperature, which we call hypothermia, a high temperature, which is hyperthermia. And with those two conditions, the skin is going to be different. So in the hypothermia, low temperature deals, how would you expect the skin to be presenting?
Pale.
What was that?
Pale.
Okay, pale.
Mottled.
Mottled.
Cool to the touch.
Cool to the touch.
Pretty much the exact opposite of sunburn.
Exact opposite of sunburn. Don't forget cyanosis here. As the skin is cold, the extremities are cold, blood is being shunted to the core of the body. So the first thing that you're going to see with the skin probably is going to be either a pale or a blue color. That cyanosis would be the skin turning that blue color. So as the blood is leaving the exterior going more central, you're going to see that. So cool to the touch, paler, mottled into cyanosis in the later stages. What about the texture of the skin? Loose, tight? How's it going to feel?
I'm going to say tight because everything's trying to constrict.
Yeah, exactly. So it should be more tough feeling, tighter. You probably won't have it very loose feeling, that sort of thing. So, and then on the other end of the scale with the hyperthermia, this could be people that are overheated. This could be fever type people. What's the skin going to be like there?
Hot, sweaty.
Okay, hot to the touch could be a diaphoretic, meaning sweaty. What else?
Kind of reddish.
Red, pink, red colors. Sure. So that would be things to think about when you're assessing people. So even if you're not taking temperatures, if you're assessing the skin, you're going to see these things, even though you don't have a physical number to go with the temperature. But it may, if you start seeing skin that looks like these things in one category or the other, it may prompt you, hey, I should probably take a temperature on this person and see where their temperature is, right? Typically, we're only going to do this if we're suspecting that they're septic or they have a fever. And we say, well, they have a fever, let's see what it is. And then we get a number to correlate with that. But think about it on the cold end as well, because, hypothermia is a big deal for us. And if that core temperature is low, then we need to do some easy warming conditions for them, warm them up nice and slow, take it easy, be gentle with them, and get them back up to where they need to be. All right. So I will tell you that when we do patient assessments, if when we're in the classroom doing patient assessments, when we're doing TSOPs, those types of things, I think the most common thing that people miss more often is skin assessments. Because we're in a practice mode or we're in a mock patient mode, they miss that more often than anything else. All right, so the next thing that we need to talk about is the pupils. What does assessment of the pupils give us as far as information?
If they're active or reactive.
Okay, that's what we're looking for. We're looking for them to be reactive to light. So, if we shine light into somebody's pupils, they should constrict. And then if we take the light away, they should dilate back out. That would be the normal. And we would hope that both eyes are the same. So if we're finding things other than that, what is it indicating for us?
We got some problems in their brain.
Potentially
trauma or overdose or something to that nature.
Right. So the biggest two things that should pop into your head is drug use or drug overdose and head injuries. those are probably the first two that you should be considering. So with drug use or drug overdose, what would we expect the pupils to look like?
They're gonna be pinpoint.
Okay, so pinpoint meaning constricted, not reactive. And what does that indicate for us? What type of drug use is that?
Opioids, I think.
So with the opioids, we would expect to see constricted pupils. That means they would be very small. Probably they would be small already. So when we expose them to light, maybe not react very much. Not going to get too much smaller. Indication of opioid, narcotic type stuff. And then are there drugs that would go the other way with dilation, where they would be fully dilated?
Alcohol, ain't it?
Okay.
I think most drugs honestly dilate the pupils.
Yeah, most do. Most of the drugs will. And then there's a few that'll take the pupils to a constricted look. The other thing is head injury, brain injuries, increased cranial pressure. So that should be the other thing, and we will distinguish between these. Hopefully, given the situation and context clues about the environment, we can distinguish between the two. But if we're dealing with brain injuries or increased cranial pressure, what are some of the things we could expect to see from the pupils?
One reactive, one not active at all.
Okay, so they'll be acting differently.
One could be blowed out, or they both could be blowed out.
Okay, they could be non-reactive. And what's the third choice if we were having pupil issues where they were maybe not reacting normally, or if they were opposite or different? What's the third choice of a problem that we could have?
They act in the opposite of what you would expect.
What would cause that?
I'm not sure.
Okay.
Spinal
So-
trauma.
What's that?
Spinal trauma.
Well, not spinal trauma, but we will talk about trauma here. So if they're not reacting appropriately, meaning getting smaller when we give them light or bigger when we take light away, drug use, head trauma, or brain injury. And then the third thing is going to be just simply an eye injury. They could have had an injury specifically to one or both eyes. So getting hit or having something that get into it. It could be a chemical. It could be some trauma force, something like that. So 3 possibilities for pupils not acting right, not doing what we would expect them to do. The normal we expect is that we shine light into their eyes, their pupils get smaller. We take light away, their pupils get bigger. Anything besides that, we're going to have to investigate as to what's going on and why. And I would say those are probably the 3 top choices. Either some sort of drug, some sort of head or brain injury, or it's an injury to the eye. again here, you need to be asking some questions though, because I've seen people that have unequal pupils. One's big, one's little. I've seen people that have unequal pupils, and that is their normal. And the reason it's their normal, I know a guy that's this way. The reason that it is his normal is because years ago he had an eye injury. And as a result of the eye injury, he does have vision, but for whatever reason, the pupil does not react. So the one is always dilated. It's big. And if you shine light in it, it's still big, even though he can see out of it. So when you see that stuff, and the reason we found this is because we were doing one of these EMT classes and we were checking pupils, and people were checking his, and they were freaking out. So I looked, and sure enough, his are unequal. And I immediately, knowing the guy, immediately suspected a brain injury because he's not right. But he told us that he had an eye injury years prior, and that's what the result was. So this would be some good follow-up questions to figure out, is this normal or not, before you go getting all, flustered and bent out of shape and starting to, take some drastic measures. Does that make sense?
Yep.
Okay, cool. The last thing we're going to talk about in the vital signs and checking part is getting to the cardiac monitor. We talked about blood glucose, so we know you guys are doing finger sticks on a lot of people now. Maybe not quite every single person, but we're mostly getting finger sticks on just about everybody, right? So checking those folks out. But when we get to the cardiac monitor, there's some things that we can check on, and we use the monitor for a lot of things now. So it'll do the pulse ox, it'll do the capnography that we talked about. We can hook them up to the 4-lead and the 12-lead, right? And get those heart things. And so as part of your AEMT world, you guys are not, you're still not allowed to do cardiac monitoring, because cardiac monitoring is a paramedic skill by the state of North Carolina. But you are allowed to do 12-lead acquisition. So just like the EMTs, you can do that now as EMTs. You can continue to do it as AEMTs and get the 12 leads. But in addition, there are 6 cardiac rhythms that you guys should be able to identify. So when you put that 12 lead on and you acquire it, print it out, there are 6 rhythms that you guys should be able to identify by looking at them. Now, we're not going to, technically, you cannot interpret 12 leads, but when you see these 6 rhythms, we're going to give you some rules that you go by, and you should be able to discern if that rhythm is one of those 6, and that should steer you to a few things. So I want to find it. I'm going to give you some rules here, if you guys can see it. Can everybody see that?
Yeah.
Okay. So we're going to talk about sinus rhythms for a minute on a monitor when we take one. And these are the rules for a sinus rhythm. So I don't know if you guys want to write this down, jot it down, whatever you want to do. And then I'm going to pull up some another thing and show you what I'm talking about when we look at a cardiac rhythm. I'll give you just a minute to write this down if you want to. All right. Let me see if I can. So these are the rules. You got those. Let me see if I can get you to. I got to. Here we go. Where did it go? Do you guys see the PowerPoint on the screen now?
No.
No, all we see is your,
My courses.
yeah.
See my courses. Do you see it now?
Yep.
Okay, good. All right, here we go. So when we're looking at these 12 leads, crap. What happened? I lost it. All right, here we go. You guys can see that now?
Yeah.
Yep.
Okay, here we go. So let's talk about, we're going to give you this basic 12-lead thing to look at, basic looking at heart rhythms on a strip type of thing so that you guys can recognize. We're going to talk about these 6 rhythms that you need to be able to recognize. So what you see on the screen is a series of pink blocks, and those pink blocks are on the printer paper that come out of your cardiac monitor. The blocks are a representation of time as they move across from left to right. So the pink blocks, there's some little teeny blocks. Do you guys see my arrow on here?
Yeah.
So each one of these little small blocks is a representation of time. And then there's a bolder, bigger box that is also a representation of time. So those are the 2 things that we're going to reference. The each small box is equal to 0.04 seconds. And then each big box, the bigger, bolder box, is 5 of the small boxes. So each bold box is 0.2 seconds. And those are the 2 time frames that you need. So 1 small box, 0.04 seconds, 1 big box, 0.2 seconds. And that's the time. So we're going to go left to right on the paper. So when we print these things out, you're going to look at them from left to right. That's how we're going to go. So this line, this black line going across, it refers to this as the isoelectric line. So that's kind of like the starting point. The 0 line is where it is. And then you'll notice that the first wave we refer to as a P wave. That's your first wave. Then that goes into this taller wave, which is your QRS complex. That's a 3-part thing. So Q down here, R at the top, S is down low below the isoelectric line. And then the last part of it is the T wave. So what these refer to is the P wave is indicative of atrial contraction in the heart. So when the atrium contract, that is identified on your rhythm strip as the P wave. And then when the ventricles contract, that is identified by the QRS complex. So that whole tall thing is the ventricle contraction. And then the T wave at the end is the repolarization. So that's when the heart is refilling with blood. And once it does that, the next thing that you would see would be another P wave for atrial contraction, followed by this whole thing repeating. So when you look at our rules that I gave you, based on the rules are mostly based on time. So the P wave, we talked about it being rounded. It's rounded and it's upright. There are some issues where it would be flipped over and it would be going down below the line. So that would be outside of the norm. So the norm would be an upright and rounded P wave, followed by a QRS complex, which we have, followed by a T wave. So that's the norm. The width of this QRS complex, the duration, would be less than 0.12 seconds. So from the start of the Q, you see the lines here. They've drawn these dashed lines for you. So start of the Q to the end of the S would be less than 0.12 seconds, which means it's less than 3 of those small boxes. and that would be normal. The this PR interval, so the beginning of the P wave to the beginning of the R, that would be less than 0.2 seconds. So less than 5 of those small boxes or 1 of those big boxes. That would be normal. And as long as you have those things, then the other thing we want to look at is regularity. So we want to see these things when I show you a strip, we want to see these things evenly spaced out, occurring at a regular basis. And when we have that, we can we have a rate of 60 to 100 for the adults. So if we have a rate of 60 to 100, we have a regular spacing of these items, and then it falls in those time parameters, less than 0.12 seconds for the QRS, less than 0.2 for the PR interval, and then we have the rounded upright P wave, followed by the QRS, followed by the T wave. Then we can define the rhythm as a sinus rhythm. So you guys see that rhythm?
Yeah.
Yeah.
Right. So typically when you see a little strip like this, the overall time frame from left to right is going to be 6 seconds. So if we assume that this strip is 6 seconds left to right, how would we figure out what the rate is?
Is it 70?
How'd you figure that out?
Counted the waves. And
Yeah.
then it takes, and you said it was 6 seconds. So you had to times 10 to make 60 seconds. So all I did was count the number of waves times 10.
Okay, so typically what we'll do, that's right on. The easiest one to look at is the QRS complex, which is the tall one. So each one of these QRS complexes represents the ventricle beating, so that one ventricle beat. So if we come across, there's 7 of them across in the 6 second time frame. So if we multiply that by 10, then we get a heart rate of 70. So that is how we would do that. We just need to know the length of the strip and what kind of time frames we're looking at. So in a 6 second strip, this heart rhythm here would have a rate of 70. So is that in our normal parameters?
Yep.
Okay. Now look at it. Does it look like it's evenly? Do these QRSs look evenly spaced out?
Nope.
Okay. For the most part, you can see that they're a little bit off.
But they're evenly spaced with with the ones that are off. They're spaced correctly. Like, what is it? 1, 2, 3, 4, 5. 1 and 5 match.
Right. And you can see with the paper that they happen at different times, but if you look at if you were to put some kind of measuring device in between them, they're not off by that much. So just by eyeballing it, it looks they're happening fairly constantly, right?
Yep.
So that's good. What about the duration of this QRS? Is it less than 0.12 seconds? from the start, which would be down here, to the end, which would be over here, is that less than three of those boxes?
Looks like it.
Yeah.
Yeah, it is. It looks like it. Is there a P wave before each one of them?
Yeah.
It's an upright, rounded P wave. Looks fairly similar all the way through. So you have a P wave, a QRS, that's your T. P wave, QRS, that's your T. P wave, QRS, that's your T. So they're happening all the way throughout, right? And then the only other thing we need to look at is the interval from the beginning of the P wave to the beginning of the R wave. And is that less than 5 of those little boxes?
Yeah.
I got 3 and like a half.
Okay.
But then again, it's a little blurry too.
Yeah. Some of these are hard to see. And you'll go blind looking at these little boxes on your printer paper. But yeah, it should fall in that less than 5 box range. So with that, we have a rate of 70. We have less than 0.12 seconds for the duration of the QRS, less than 0.2 for the PR interval. We have a P wave, a QRS, and a T wave throughout. They're rounded, they're upright, it's regular spacing. So would you guys define this as a sinus rhythm?
Yeah.
Yeah, this would fall into that category. We could say this is a sinus rhythm. So that's the first rhythm that you should be able to identify as a sinus rhythm. If we had a rate, if everything looked like this, but the rate was less than 60, what would we call the rhythm?
Sinus bradycardia.
Yeah. And that's what you would have. If this were a 6-second strip, what would the rate be?
$50.
50. So if we had a 6-second strip here, this would be a rate of 50. And trying to make it as big as I can without jacking you up. Quit messing with it. So this would have a rate of 50, which falls outside of our normal parameters. But does everything else fall within the parameters? P wave, QRS, T wave, fairly regular spacing, durations less than 0.12 there, less than 0.2 there. If everything else matches, then this would be a sinus Brady rhythm, right?
Yep.
And then, do you guys see the 3 little marks at the bottom of the paper?
Yeah.
For this strip? There's a mark, there's a mark, there's another mark at the end. Those 3 little tick marks. The 6 seconds is from the first mark to the third mark. That's the 6 seconds. By that, what would the rate be if you followed that guidance?
130.
130. Okay, so that's above our 100 in the normal range. So look at everything else that's going on here.
Minus tachycardia.
QRS duration is less than 0.12 still. We have a P wave, QRS, and a T wave throughout. They're happening fairly regularly, right? Equal spacing, just about. So yeah, this would fall into the sinus TAC category because it's greater than 100. And typically, in sinus tach, we're going to have a rate usually between 100 and 150, because once it gets over 150, we're going to throw it into a different category. So this one would fall in the sinus tach category. So those are the three rhythms. That's half of your rhythms that you need to know. You have a sinus rhythm, and then the only thing that changes outside of the sinus rhythm is the rate. For sinus tach or sinus brady, the only difference is going to be the rate. Does that make sense to you guys?
Yep.
Okay. The other three rhythms are ones that we're going to have to take some action on. So we'll start with this rhythm. The fourth rhythm that you need to learn. This rhythm here is V-fib. Okay. And what V-fib means is that there is electrical. Wait a minute. I'm not sharing this with you, Emma.
Nope.
Thanks for telling me. There you go. You guys see this on the monitor. What this is showing you is it's electrical activity, but there's no organized beat to it. This is erratic electrical activity. So it's all over the place, which is why you see the craziness. And you cannot discern any recognizable part of a heart rhythm. There's no P waves, there's no QRSs, there's no T waves. It's just an erratic squiggly line. And what that means is V-fib. So in V-fib, the heart is quivering. It's not beating. It's just kind of shaking. So because the atrium and the ventricle is not beating, not contracting, no blood flow is moving, and the electrical activity is just all over the place. And that's what this is representing. Electrical activity all over the place. Right?
Yep.
So what is the treatment for this?
Shock the crap out of them.
All right. So if you put them on a monitor, what is this patient going to look like? If this patient is in front of you, what are they going to look like?
They're going to be unresponsive, unconscious.
Yes. They're going to be unresponsive. Are they going to have a pulse?
No.
No, they're not, because there are no heartbeats going on. So this person is unconscious, unresponsive, no pulse, by definition dead. And the treatment for this is defibrillation. So if you see this on your monitor, when you hook your monitor up to the patient, whether you're using the leads, the 4 lead, the 12 lead, or the defib pads, whatever you're hooking up to your patient, you should see this on there. And if you see this on there, if you didn't hook the defib pads up, you need to, because they need to be defibrillated. And then once you do that, this is CPR appropriate. You'll be working your stuff. If you defibrillate them, hopefully this will change to something better, where you can get this patient back into a manageable state. What would you need to do if you defibrillate this and it stays like this, and you defibrillate this and it stays like this, and you defibrillate this and it stays like this? If you were to defibrillate this like 3 or 4 times and it stays like this, do you know what you need to do?
Take them to the hospital so they can get an epi drip.
Nope.
Keep doing chest compressions and keep shocking them.
Keep doing compressions, but we're going to change the shocking. What you need to do If you have persistent VFib and you keep shocking it and it won't change out of VFib, you need to hook 2 cardiac monitors up to them and shock them with 2 monitors.
You just take biphasic and try to make and get the joules for monophasic.
No, we're just going to double defibrillate them. And there's 2 ways you can do it. You'll hook the pads up, and you know, when you hook pads up right now, you put them in the right upper chest and the lower left side. So do that. And you know, with kids, you can put pads on the center of the chest and the center of the back.
Yep.
So you would do that. You need 2 monitors, 2 sets of pads put on them, and then you can do both monitors at the same time with a double defibrillation, or you can do one followed immediately by the other. So it'd be like a hit type of thing. But if you're working on somebody that's in VFib and they won't come out of it, I've seen this one time, and you know, they were in VFib for like 20 some minutes, and they were defibrillated about 8 times. So, and it stayed there. But the treatment for that now, and it's a specific treatment for that now, is to double defibrillate them. You need 2 monitors, and you'll hook both monitors up and hit them with both monitors.
Is that in local protocol now?
It is.
Okay.
But that is that's the one you need right there. So that's VFib. Number 7 here, this one. This is VTach. So you have ventricular fibrillation up there where no beats are happening. This is ventricular tachycardia. So this is basically a runaway ventricle contraction. Each one of these humps is a ventricle contraction. You can see how wide they are. So they're much wider than that 0.12 seconds that we're looking for. And you can see how often they're happening. So if this were a 6-second strip, what kind of rate would you be looking at?
$160.
Right. Something like that. And typically these will be going a lot faster too. They'll get up faster than that. So what's happening is the ventricle is beating so fast that it doesn't let blood flow into it before it contracts. So it's just constantly contracting and essentially pumping no blood. At the slower rates, you know, if it's like 150, 160, it's very possible that that your patient will have a pulse. It's even possible that they'll be awake, they'll be conscious, they'll be talking to you, they'll be complaining of chest pains and things like that, but they will be awake, alert, and they'll have a pulse. So if they are in that condition, we have a different treatment for them. If your patient is in this rhythm and they do not have a pulse, if they're not awake, alert, responsive in any way, and they do not have a pulse, what's the treatment for them?
You shock them.
Shocking them, yes. It's the exact same treatment as the VFib. So VFib, they definitely won't have a pulse. VTach, they might not have a pulse. So you're going to have to assess the patient and find out. If they do not have a pulse with VTach, it is the exact same treatment as VFib. If they do have a pulse, it's completely different. So don't get carried away. Although if they do have a pulse, I want you to be prepared for them to not have a pulse. You should be preparing that that pulse is going to go away. All right. And then we have one more rhythm for you. It looks something like this. So this is called asystole. You guys see that?
Yep.
And what does that mean?
That means you ain't got nothing going on. You ain't getting shocked.
Okay, so if they are asystole, they have no electrical activity. There's nothing electrical happening in the heart, and it's indicative of this line that is fairly flat. By flat, we mean that you won't see a P wave or a QRS or a T. You may see some waves in here. You can see how it elevates here in the middle, but there's no electrical activity happening. So we do not defibrillate this. If we're going to do anything treatment-wise for them, what are we going to be doing?
CPR.
Yeah, CPR. This is going to be your working your code thing. So CPR, airway management, IVs or IOs, epi 1 to 10, 1 milligram every 5 minutes, trying to see if anything changes with that person. When somebody's heart stops, what kind of time frame are we looking at before we get to this point? Average.
6 to 8 minutes.
Yeah, somewhere along in there. Probably less than 10 minutes. This is what you're going to go. So if they have a beating heart and it stops for whatever reason, the electrical activity is going to go, if nothing is done to them, it's going to go to this probably within 10 minutes. So be aware of that. Okay, so those are your 6 identifiable rhythms at the AEMT level. We're going to work a lot more on these in the labs. We're going to get you the paper out so you can see it. We're going to print some strips out for you so you can see them and create some rhythms for you to get you looking at them and familiar with them. Okay, so should be a good time, and we'll get you more familiar with that type of stuff. You don't have to learn every rhythm that's out there because there's a lot, and you certainly are not getting into the mode of interpreting 12 leads at this point, but we do want to give you the basics, which we did, and get you in the mode of recognizing some different things. And when you guys print these 12 leads out, don't just print them out and lay it down or hand it off to somebody. You can get in the mode of looking at regularity. Is this happening regularly? Or is there some other things, some irregular parts that are going on? I'm trying to see if I have one that's readily available that has some irregularities in it, but I don't there. Tell you what, I'll find you one real quick. All right, so it's supposed to be this hard. I'll show you this real quick as well, just so you are familiar. You know, one of the common heart problems that we deal with is heart attacks. We refer to those as STEMIs. And we'll give you a little bit of that when we get into the lab. But the STEMI is the ST elevation. So when we talk about the normal wave, the P wave, the QRS, and you see how the QRS, where the S is below that isoelectric line, and then it comes back up to the T wave. With the elevation, that S stays above the isoelectric line. It doesn't drop below like a normal one would. It stays elevated, and you'll see that elevation. And when we look on the 12 lead, you know, we'll get into that a little more in the lab this week, but I'll show you guys how the leads group together and what categorizes people to fall into this ST elevation category, where we are determining, yes, they are having a MI or not. But that's what we're going to be looking for, is that raised section right there. All right. So we want to get you guys thinking a little deeper on these things, diving a little more into it. When you get into chapter 19, it's going to talk about history taking. It'll talk about the relevance of history taking. When we talk to some of our patients and you ask them for their medical history, you know, they could be 70 years old and they'll tell you that they broke their arm when they were 10 or something like that, which probably won't be relevant for what we're dealing with. But we have to filter through that information and take into account what's relevant now for what's going on with them now. Again, finding out what their normal is a big deal, because everybody's normal is a little different. They may have something which we think is abnormal, but it could be their normal. So we need to determine what their normal is before we start taking a lot of intervention measures for something that doesn't need to be fixed. You'll see in chapter 19, it's got a lot of the mnemonics that we use. So all of the sample questions they talk about, the OPQRST stuff they talk about, the DCAP BTLS. So all of those things, they're going to define trauma patients for you. What categorizes somebody as a critical trauma patient, those things that we need to be looking at, which is going to affect our transport decisions. If we have critical trauma patients, we need to be making some good decisions about getting them to a trauma center as quickly as possible, not necessarily taking them to these little Band-Aid stations that we have just because they're close. But we may need to take a few minutes and manage this patient to be able to get them, you know, into a critical care thing and get them on their way to a trauma center rather than just turning them over to the local hospitals. So we're going to have to make some decisions there and think things through. If we can manage them for 10 or 15 minutes and then be able to put them in a helicopter and send them to a trauma center within 15 or 20 minutes, that could probably work out a lot better than just having them with us for 10 minutes and throwing them off into the local hospitals where they would have to stay for maybe a couple hours before they can get to the trauma center. So that could have a big impact on the continuum of treatment and the outcome all the way down the road. All right. So there's a lot of terminology in these two chapters, a lot of medical terminology. A lot of it, I will tell you, a lot of it we don't use. When we're talking about people's breathing, Has anybody ever used the word eupnic when we talk about somebody's breathing?
No.
Do you know what eupnic means?
No.
Absent of air?
No.
Nope. ain't
Eupnic,
got clue then.
Oh, is that good breathing?
eupnic means normal breathing.
Apneic is the absent of air, right?
Apneic is not breathing.
Yeah.
The absence of, but eupnic is normal breathing. And when we talk about people's breathing, their respiratory rates, their abilities and all, I don't know anybody that's using the term eupnic, but I can tell you it's in this chapter. I can also tell you that I've seen it on tests as test questions in previous years. So even though we're not using it necessarily, it doesn't mean that you need to not learn it, not worry about it, not study it. Okay. These terms are here. If they're bold-faced terms, you need to talk about those and use them. They talk about a lot of conditions in this chapter, the 18 chapter, with different breathing things, different pulse things. So make sure you're going over those buzzwords and the bold-faced words, so that you don't get tripped up on a test question just because you didn't learn the definition. Anybody have anything? We're about to cut out of here. We're at the end of our time coming up. We've got about 5 minutes left, but does anybody have any questions or anything before we shoot out of here?
The in FISDAT, if it don't say Vidant Hospital, that means I can't put that shift in there, right?
Yeah. Does it not list any Vidant hospitals?
No.
Yeah, there are
I
no
don't even
Vidant
have-
shifts. I was just looking at that.
I say I don't even have Albemarle in there. Like on the lab sites where you can put in urine Perquimans and then it allows you to do the lab.
Yeah.
Like, it won't even let you pick that you're even at a hospital.
That doesn't sound right.
For mine is showing it's got an opening on the 28th, 29th, 30th, and 31st, but they're all at Centera.
Okay. So
Oh, let me actually get off my mobile and go here. But I know, like, I just tried because I've been sitting here messing with it, and it won't let me create a shift for.
Oh yeah, if we don't have it on FISDAP, we can't like log all of our stuff, right?
right.
Because what I've been told is whoever you're working with that for that patient has to sign off and lock that report for you.
Yeah, your preceptor in the hospital, you'll be assigned to a nurse, and your preceptor will be that nurse, and whoever that nurse is, when you get at the end of your shift, you need to have logged all of your patient contacts, so whatever assessments you did, whatever skills you did, and then that nurse needs to sign it so that you get credit for that shift. I'm trying to. Where's that stuff in here? I'm trying to find out where you're
Under shifts.
under shifts,
Skills and patient care.
skills and patient care.
Now I try to call Cameron too. She's in a meeting until 11. I got a message back from her.
Okay. All right, so I can pick one of you people.
But now it won't even let me like quick add a shift either, because it says quick add shift created by student. It won't even let me do that.
All right, let me look at Brian here. I'm looking at you, Brian. See, I can only see the shifts that you've put in.
Which has been 0 because Cameron's supposed to fill them in for us. According to her email, well, I don't know if she wrote that in the email or she told me that on the phone the other night. But I worry the shit out of that girl.
Well, you need to make sure this is right. All right, I see, all of your lab shifts that you've put in. And
Now, so if I go to skills and patient care,
yeah.
like I'm getting ready to set it up, and I go to lab shift, it will not let me do a hospital. It says lab site, College of the Albemarle, Dare County EMS or Perquimans emergency services. And then
That's because you're doing lab shift. You need to be doing clinical shift.
okay.
Okay, so Cameron put mine in for me because I'm doing 3 next week at our mall, and I went FISDAP and I went to shifts, schedule,
Mm-hmm.
and then put it as the month, and there's little stars on the ones I'm on. So I clicked on it, and then you can go in. It says skills and patient care.
Okay, so she needs to put the stars by our name then.
Yeah, you're not evidently in scheduler because you would have got an email that says she put you in there for those days.
Okay. That makes sense now.
And then it brings up my shift where I can start, you can't do anything yet because it's not happened, but you'll be able to put in your patients and then it could be locked.
All right, because she's got my days, and she's according to her email, she already forwarded them to Susan. And then when Susan messaged me back, she was like, "Yeah, blah blah blah. I'm happy to see you. Meet at 1:00 today." And then tell me where the thing, and so I can get all my crap situated, so I can go preset.
Okay. So,
But yeah, I'm supposed to start precepting tonight at 6.
all right. So we'll get you straight today. I'll be talking to her, and we'll get Mark straight today.
I'm about to say I really want to ask the question, but except for
If you go under schedule, Vidant Chowan is in there. They have a list of 18 preceptors, which are all the ER nurses.
Where's this at?
I'm under shifts and under schedule.
All right, let me go to schedule. Alrighty, and where do I go from there?
On the calendar, I was at the very top edge of the calendar.
Oh, here's one that says add lab shift. Hold on. No, still wrong
No.
one.
You
Never
don't want to add a lab shift. You want a clinical shift.
That's where I am right now, and it's not showing anything with your one.
Yeah, I don't see anything with Biden up here.
Okay. I'm sure that I can see stuff you can, or yours
Yeah,
looks a little
I
different.
think you have more.
No, don't say that. I have no powers.
I was about to say you have more administration authority than we do.
Nope, I do not. I don't have any authority on this stuff. But I'll be getting with her just a little bit, so we'll figure it out for you guys and get it all straight. Okay.
All right.
Have no fear.